This case is an example of suspected malignant pleural effusion recurrence. A patient with previous malignancy presents now with recurrent pleural effusion. So this patient has a past history of malignancy along with pleural effusion, and now he has a recurrent pleural effusion. Thoracocentesis is performed, which laboratory finding most strongly suggests malignant recurrence. Pleural protein, glucose, the pH, pleural LDH, neutrophil predominance. The correct answer is the pleural LDH more than 1,000 unit per liter. Explanation: very high pleural LDH more than 1,000 unit per liter indicates an exudative effusion. Exudative effusion, commonly seen in malignancy or empyema. So exudative effusion is commonly seen in malignancy. Exudative effusion is commonly seen in malignancy as long as the empyema. So malignant pleural effusion is indicated by the presence of exudative effusion and very high pleural LDH, very high pleural lactate dehydrogenase, more than 1,000 unit per liter indicates exudative effusion. The other options are incorrect. Low protein suggests transudate. So low protein suggests transudate. Normal glucose and normal pH exclude malignancy. Normal glucose and pH exclude malignancy. Neutrophil predominance indicate infection. N. Neutrophil predominance indicate infection. Lactate dehydrogenase, very high LDH indicate malignancy. L, malignancy. LDH, malignancy. Neutrophils, infection. Low protein transudate indicates transudate. So let's talk about a case of malignant pleural effusion. 42-year-old woman with shortness of breath received the chest X-ray. This is a unilateral pleural effusion, unilateral malignant pleural effusion. Chest X-ray, 2 views, shows increased opacification of the lower and the lateral left hemithorax with a meniscus sign. This chest X-ray showing increased opacification of the lower and the middle aspect of the left hemithorax with a meniscus sign. This meniscus sign indicates pleural effusion. So there is increased opacification of the left hemithorax with a meniscus sign. This is the lateral chest X-ray. Okay, can you see the meniscus sign here? Okay. So there is also increased opacification here with a meniscus sign of the left hemithorax with a meniscus sign. This is the normal cardiac opacity. Okay, this is the normal cardiac opacity here should be translucent, shouldn't be that opacity indicating opacification, and here is the meniscus time. The mediastinum is shifted rightward and the diaphragm is shifted inferiorly. You can see here that the mediastinum, this is the mediastinum, is shifted rightwards by the mass effect of the massive left pleural effusion. So the mediastinum is shifted rightwards and the diaphragm, the left hemidiaphragm, is shifted inferiorly. It's seen here clearly on the CT scan. The diaphragm is shifted inferiorly. The mediastinum is shifted to the right side. The mass effect is better seen on the subsequent CT scan, as I mentioned, the mass effect and the mediastinal shifting, contralateral mediastinal shifting. This axial CT scan, contrast enhanced CT scan, showing this. A small nodule is seen along the anterior pleura. A small enhancing nodule, is seen along the anterior aspect of the pleura. For unilateral pleural effusion, the differential diagnosis should be infection, empyema, okay, malignancy, trauma, hemothorax. So the differential diagnosis of unilateral pleural effusion, the first one to come into mind is the malignancy, then trauma and the infection. Malignancy, then trauma and infection or empyema. For any case with unilateral large pleural effusion, you need to think of 3: malignant pleural effusion, hemothorax after trauma, empyema with infection. Again, malignant effusion, hemothorax with trauma, empyema with infection. If you find an enhanced nodule, this is most likely to be malignancy. So if the effusion is causing mediastinal shift and downward displacement of the hemidiaphragm, as I mentioned, if the effusion is causing mediastinal shift and downward displacement of the hemidiaphragm, this is called effusion under tension. Effusion under tension. However, if this is a pneumothorax and is causing mediastinal shift and the downward depression of the hemidiaphragm, it's called tension pneumothorax, okay? So here, this case is an effusion under tension, okay? Both of effusion under tension and the tension pneumothorax require insertion of the chest tube, okay? So here, this effusion under tension require drainage on an urgent or emergent basis. This is very important. Whenever you see effusion under tension, the first line treatment, drainage on an urgent or emergent basis. If the patient is hemodynamically stable, CT may be performed as this patient. This patient, CT is performed as the patient is hemodynamically stable. If the patient is not hemodynamically stable, okay, drainage on an urgent basis. A CT scan may be performed for further characterization. CT scan is performed for further characterization. So here in this case, the CT scan revealed this enhancing nodule, indicating that this effusion under tension is of malignant etiology. Thoracostomy tube planning, okay? Thoracostomy tube, thoracostomy or chest tube insertion, okay? So the mainstay treatment here is thoracostomy or chest tube insertion for drainage of this effusion under tension. It is the same here. A patient with previous malignancy and with recurrent pleural effusion, thoracocentesis is performed. Thoracocentesis or chest tube chest tube is inserted, okay, and the laboratory finding, okay, while taking sample of the pleural fluid, these are the finding, okay. From these finding, okay, if the pleural LDH more than 1,000 unit per liter, and if the pleural protein is not low, the pleural protein should not be low, as low pleural protein indicative of transudate, okay, it's not exudate. So if the pleural protein is low, this is transudate, this is not exudate, and the exudate pleural effusion, exudative effusion is indicative of either malignancy or empyema. So pleural protein shouldn't be low. Glucose shouldn't be normal, as normal glucose will exclude malignancy. So the glucose shouldn't be normal. The pH, okay, the pH shouldn't be normal, as normal pH will exclude malignancy. Pleural LDH should be high. Neutrophil shouldn't be predominant, okay, as predominant neutrophils is with suggestive of infection. Predominant neutrophils suggestive of infection, which exclude malignancy.